Hey, good evening, everyone. So we'll get started here very soon. I know everyone's it's decently nice outside, minus the smokiness from the Canadian wildfires. But yeah, we'll try to get through this. And really, I think the best part of these webinars is any questions that y'all have. Please feel free to put it in the chat box on the right of the screen, and I would love to go through those and try to, as much as possible without examining a patient, just try to get through some questions that you all may have, and we'll definitely do that. Yeah, so thanks so much for tuning in. My name is Dr. Paurush Babbar, and I'm with the Urology group here in Cincinnati, and the topic of our webinar tonight is the treatment of erectile dysfunction. So just a little bit about myself. I actually grew up in Melbourne, Australia, and I moved to the States for high school in Atlanta, Georgia, and then went to Wake Forest in North Carolina for my undergrad, and then stayed there for my medical school training. And then what I consider one of the luckiest or greatest or whatever things that ever happened to me was that I got selected to go to the Cleveland Clinic for my residency, which is the preeminent institution for urologic care, I think, in the United States. And there, I was able to be exposed to really the whole gambit of urology, kidney stones, female urology, cancer cases, and really always what stuck with me, that was my passion, and was then and still is now, is men's health, men's sexual health, male reconstruction, and issues such as erectile dysfunction, which I think just have such a great burden on men. And as men, I think we are not very good about talking about our problems. I think we bottle it up until it's much later and it causes psychological distress. So I really commend everyone on tuning in today. I think this is a great first step. And one thing I want everyone to do is make a note of those phone numbers there on the side and call and come see us. That's the first thing we can do. No, I guarantee you, I've heard, anything that you think is embarrassing, I hear it a few times a day. It's not embarrassing, and you don't choose to have these issues. You don't choose to have erectile dysfunction or testicular pain or premature ejaculation, but you can certainly choose to treat them. So and then I luckily stayed on for a year at the Cleveland Clinic. I was selected to stay on for a fellowship in male reconstruction, prosthetic surgery, and men's health. So that was just a year of training with two of the greatest mentors, Ken Angermeyer and Hadley Wood, on really advanced topics and how to treat complex issues that we'll be delving into today. So I see patients at the Eastgate and Norwood office, and yeah, please come in and see me. Would love to help. So erectile dysfunction, what is it, who has it, and what causes it? So erectile dysfunction is the ongoing inability to achieve or maintain an erection firm enough for sexual intercourse. So by definition, I think erectile dysfunction is a subjective thing, meaning that for one patient could be a good erection, something that they're happy with, another patient may not be happy with it. So it's fully dependent on a patient's own personal perception. And so it can also be an indication of an underlying issue, and we'll go into that a little bit, such as heart disease, low testosterone, psychological, anxiety, depression. And so it's very much intertwined with a man's overall health and psyche. So it is very prevalent. 1 in 5 American men over the age of 20 will experience ED in their lifetime. I mean, that's what they say. I think it's higher than that, just given my practice and how busy we are and things of that nature. So 50% of men over the age of 50 have erectile dysfunction. And we think at least 30 million American men are affected by erectile dysfunction. And so this is a vastly undertreated issue. And so, it's things like what we're doing tonight to kind of spread the word that we have options and that we can help patients, who are experiencing this problem. So this is, I think this slide's a little too busy, I think, but essentially what this says is that how an erection works. To me, I just think of it in that there's blood flow in, blood flow out. If there's, either not enough blood flowing in or the blood is leaking out too quickly, then there's a mismatch, and then that's erectile dysfunction. And certainly the other thing that plays into it is nerves. And so that controls sensation, but also the initiation of an erection. So all these things go into it. I mean, this slide is more for someone like myself to really understand, and for board exams and things like that. So what are some of the common causes of erectile dysfunction? So we think that that it can correlate with overall poor health. Things that I think about with erectile dysfunction: low testosterone, which correlates with low libido, fatigue, weight gain, loss of muscle mass. Then definitely pelvic surgery. So the thing we think about there is prostate cancer. So prostate cancer is the most common cancer in men after skin cancer. And the treatments for prostate cancer, whether it be radiation, surgery, hormonal manipulation, those all can be implicated in erectile dysfunction. And so it's very important that your urologists know about that, and we can help with that. And then other things that, especially in younger patients who I see who have erectile dysfunction, depression, anxiety is a very, very common cause of erectile dysfunction. And probably definitely the most common cause of ED in men under the age of 40. And then other thing that I really think about is diabetes, very, very prevalent condition in the United States. And so the increase in blood sugars affects arteries, veins, nerves, really all components of erection, and is one of the most common causes of severe erectile dysfunction. So, and then things obviously like obesity, smoking. I mean, it's definitely a lot of things that are implicated in erectile dysfunction. So, this slide, I think any doctor would endorse. So ways to improve your overall health: diet, exercise, weight loss, limiting alcohol, quitting smoking. Smoking is one of the worst, if not the worst thing you can do for your health. I think when I see a patient who's smoking, maybe we spend time talking about, you should quit smoking. It causes cancer, it causes ED. And if a patient will quit smoking by me telling them that you will not be able to have sex because of this, then so be it. Because it is so bad for your health. And reducing stress and sleeping well, all these things are absolutely important. So things that I want to kind of delve into, some urological issues that we see and treat that are related to erectile dysfunction. Low testosterone, which we mentioned, which is common in 40% of men over the age of 45. Peyronie's disease, which is a adult onset acquired penile curvature that we see in about 9 to 12% of patients over the age of 50. And then prostate cancer, which I mentioned earlier. So low testosterone. So the testosterone is normally made by the testicles, the vast majority in a man. And then as men age, there's a higher incidence of low testosterone, that the testicles are not making sufficient quantities of testosterone. Now, this can have a profound impact on a man's overall health. It can cause fatigue, weight gain, loss of energy, increased body fat, low libido or reduced sexual drive, and then certainly erectile dysfunction. So when I see a patient with erectile dysfunction, we'll talk about, sometimes they've already had that checked by their primary care, which is very appropriate. But if not, we like to a lot of times check testosterone and other labs that kind of go in that neighborhood: free testosterone, total testosterone, estrogen, LH, hematocrit, a few things like that, PSA. So, and then if it is low, right? So I think that it absolutely is we have a discussion, but it's important to at least have a consideration of repleting that. So, and there's ways that testosterone can be repleted. There's gels, solutions, topicals, patches. Then there's oral medications, nasal sprays, more like a nasal gel, and then pellets or injections. And then, so these are common ways. And actually, we have a comprehensive men's health center, men's wellness center, that we use to replete testosterone. And we just generally start, as long as the patient's not interested in fertility, with a topical solution. 70 to 80% of men will respond to that. If they don't, then we go to their second and third line treatments. And then we make sure we check labs and make sure that it's at an appropriate level. So this is one thing, that there are many men's health centers out there that replete testosterone. They'll have you come in twice a week and shoot you up with testosterone. And I think you have to be careful. That's what I'll tell you. I always tell patients, you want to first and foremost ask whoever is doing this, where did you train in urology? Where did you do your fellowship? A lot of these guys are not even doctors, or they're ER doctors, or what I'd say is, when I get my car fixed, I don't have my landscaper fix my car. I don't have my plumber do woodwork in my house. So I think it's important to see what's being claimed, who's doing it, and really sussing it out. That's all I'll say about that, and the rest you can decipher from there. So Peyronie's disease, adult onset acquired penile curvature. And this can be quite distressing to men because all of a sudden you look down and your penis is not what you've seen for 50 years. And so we think this happens probably because of actually erectile dysfunction, the beginnings of ED. And so if you think about when you were 20 years old, your erection was a 10 out of 10. When you're 60, maybe it's an 8 out of 10. And when you're having sex, there's a little bit of hinging in the erection and then imperceptible to the patient, their partner. And this can cause micro tears in the inner lining of the penis. And then in this 9 to 12% of men who get this condition, there can be scar tissue deposition in that tunical layer of the penis. Now, scar tissue is not as elastic as regular tissue. And then this, when you get an erection, it hooks the penis. So you can have a curve. I've seen curves up, down, left, right, combination of this. And a lot of times this can cause pain to the partner during intercourse. It can make it so that men can't even penetrate during sex. And it can also be psychologically distressing. So it's vastly undertreated due to this stigma. But there are things out there now, that's spreading the word. That you see it on Hulu all the time. There's the bent carrot commercial for Xiaflex. So people are kind of getting aware of this condition, which is great. And so Peyronie's can definitely cause loss of length. I think I tell patients every patient with Peyronie's is loss of length because both my fingers are the same length. Now one is shorter than the other. It's basic geometry. And so there can be pain with erections, ED, and issues with penetration. And so there's a few things we can do to help treat Peyronie's disease. There's a traction device, the one on the market that I like to recommend. It's the Restorect. So this is a penile traction device that essentially curves the penis in the opposite direction of the curve, and you have to use it a few months, and that can help. Xiaflex is what I was mentioning. So this is a injectable medication that goes directly into the scar tissue in the penis, and this is an 8 injection course over a few months, and can really help in a lot of patients. And then lastly, if a patient just wants to take care of this, then there's surgical procedures such as plication, incision or excision of the plaque with grafting, or if a patient has both erectile dysfunction and Peyronie's, penile implants are actually your best bet by far, because if we were to straighten your penis with one of these things, but you have no erections, then we did you no favors, right? So you can put a penile implant, straighten the penis, have a 10 out of 10 erection, be ready to go. So that's gold standard if both these things are, coexisting. Then on to prostate cancer. So like I said, most common cancer in men outside of skin cancers, and it's really the treatment of prostate cancer, which is needed. I don't dispute that. So whether it's radiation, brachytherapy, surgery, cryo, hormonal therapy, chemo, that can cause the erectile dysfunction, because the nerves that predicate erection lie on the lateral, the sides of the prostate, and so it's in very close proximity of where the cancer is and where it's treated. So in this regard, in prostate cancer, these patients will have a lot of times severe erectile dysfunction, and they'll try and to various things like pills or shots, and it still may not work. And so a lot of times penile implants can work really well here. One other thing while I'm thinking about it that is a unique thing to prostate cancer survivors, especially who have surgery, they can also have leakage of urine. So we have a lot of good options for that, whether it's slings or artificial urinary sphincters, if exercise don't work, to really help them get as dry as possible. But we, once again, we have a lot of options to kind of help restore quality of life in prostate cancer survivors. So most types of ED can be treated. Agreed. So here are some of the treatment options that we wanted to discuss tonight. So oral medications, vacuums, low intensity shockwave therapy, injections, and penile implants. So first, oral medications. So essentially, this is medications that you may have heard of, such as Viagra, Cialis, Levitra, Stendra. So these are PDE5 inhibitors. These help to increase blood flow to the penis. They require sexual stimulation, and they're effective in about 50 to 85% of men, but not as effective in men who've had prostate surgery, uncontrolled diabetics, things like that. And these medications, as we know, are rarely covered by insurance. Now, potential side effects we see is essentially these medications increase blood flow to the penis, but the penis is an extremity. So just like that, your head, it increases blood flow to your head. So you get headaches, facial flushing, nasal congestion. Vision change only happens with Viagra because it affects PD6 as well. And then Rarely. I think this is always when you hear the Viagra, when you used to hear the Viagra commercial, they're not on the TV as much, that you can have an erection lasting longer than 4 hours. It's very rare, I find, with these medications. It happens more with injection therapy, but is a side effect. So Viagra, Cialis are the two most common ones. So Viagra takes about 30 to 60 minutes to work and lasts for about 4 hours, and they say must be taken on an empty stomach, which is true. Cialis is kind of, we call it the weekend pill, so it can last up to 36 hours, maybe taken with or without food, which is a lot more agreeable with more people's lifestyles. And then one thing that I like is actually a daily option that you have with Cialis. So a lot of patients who have erectile dysfunction, older gentlemen, will also have BPH, or benign prostatic hyperplasia, in enlarged prostate. And so this causes issues urinating, where they'll wake up a lot of times at night to pee. The stream is weak. They have urgency, frequency. So taking a low dose daily Cialis can help relax the chokehold of the prostate on the urethra, so they pee better, and it helps with blood flow to the penis. So you get kind of a 2-for-1, which is great. So these are some what I would consider first line therapy for erectile dysfunction. So we at our surgery center and our facility in Norwood have an on-site pharmacy run by Melissa Reuter. And so this is an excellent service where we discreetly can mail Viagra, Cialis, medications like this to the patient. And it's, discreet. There's no lines, and they're just very, very, they're very excellent and good at, these urologic issues. So, we encourage patients to utilize this great service. Then there's vacuum erection device. So essentially, here's a picture of it. So there's a hollow tube, and a lot of times you use like a ring at the base of the penis, and then this can be hand or battery powered pumps, and they create a vacuum that pulls blood into the penis. And then these work well. The issue is that it's a little cumbersome. You put this thing on, and then you got to take it off, and then a lot of times patients will complain that when you take it off, the erection goes away. But it can be effective. I agree, in 60 to 70, 80% of men, but most men by far will decide to move on to other treatments. Now, one time I do think this is a very helpful vacuum device is helpful is in patients who are undergoing prostate cancer treatment. And so a lot of times what prostate cancer patients will say is they lose length to their penis. So, even before they go into treatment, if I meet them, I like to put them on a vacuum device to help it's kind of rehabilitation of the penis to help increase blood flow to that area. And there's some evidence it decreases fibrosis or scarring in the penis and helps to promote less loss of length. You don't want anything that promotes loss of length. And so it's something it's an interesting part of our treatment in what I would call pre-prostatectomy prehab. But it's an option in just even de novo erectile dysfunction. Next is a very interesting topic. And so this is low intensity shockwave therapy. This is something that has come around the last few years. And there's, once again, when I talked about with these low T clinics, there's a lot of this on the radio and the TV and things like that, with men's health clinics peddling, penile shockwave. So once again, I'd tell you to just be vigilant of who's doing it and what their credentials are. And so let me kind of tell you about this. So low intensity shockwave is a shockwave that is delivered specifically to the corporal bodies or the erection chambers of the penis. In randomized clinical trials out of Israel and Europe, we have seen that there is increased vascular or blood vessel proliferation, stem cell regeneration, and there's a IIEF, which is a validated questionnaire that patients fill out. And on a 25-point scale, there's a 2 to 4 point increase in erectile parameters. So it is a modest increase. So it's not from 0 to 25, like I would say a penile implant can be, but a 2 to 4 point increase. So someone has what I would say mild erectile dysfunction, you can really help them, or moderate erectile dysfunction. Someone who has a 15 out of 25 can go to a 19, back to mild erectile dysfunction. So, in the correctly selected patients, I think this is an excellent treatment option. I think that so patients who maybe are on a low dose Viagra or Cialis and have benefit, patients who are young and just having the beginnings of ED, I think this helps. I don't think this is a great option in patients who are on high dose injection therapy already. I don't think this is a great option in patients who have diabetes for a number of years, uncontrolled diabetics. Patients who've had prostate cancer surgery, I don't think are the best treatment options for clinical trials on that show not much benefit. So I think one thing I'll tell you is this. At the urology group, we do the full gambit of erectile dysfunction care: pills, shots, shockwave, vacuum, penile implant surgery. So if I see a patient who I think is not a candidate for something like this, which is the new sexy thing going on, I will tell you very frankly, I don't think you're a candidate, and we move on. A lot of men's health clinics will just do this, was they can't do surgery. They didn't go until they were 33 years old to school to learn how to do it. So they're just going to say, no, you should do this, because they're businessmen, they're salesmen. So you got to be careful. But the key is this: to run the correct shockwave, which is low intensity shockwave, focal shockwave therapy, you have to be a urologist, right? It matters that you have the correct machine, the correct training. Anyone can run radial shockwave. This is the same FDA class as a photocopy machine. So it makes a noise, but the depth of penetration is not enough to get the benefits that I was describing in these clinical trials. So you have to be very careful and with which one you go. We talked about how it works, and I talked about this. Yep. So we are the first group of urologists in Cincinnati. That's the key urologist offering shockwave therapy for ED. We have a staff of ED experts with decades of experience, and we stand behind this, and we really understand your medical history, things like I was talking about diabetes, prostate cancer, things like that, before we, recommend the therapy. And if we don't think you're a candidate, we'll also tell you that frankly too. So, this is the QR code. That's the number to call. I think that there's a free consultation that you can have, and we'll quickly go through a few questions. And if you're a candidate, then we'll go through it with you. And if you're not, then we'll set you up with one of our ED specialists, such as myself, to go over what is an option for you, right? Now, a few things is that all these trials show there's no negative effects from it, thankfully. So no hematoma or blood collection in the penis, no penile pain, no ejaculatory issues, nothing like that. So it certainly can help. It's not going to certainly hurt. And the side effect that I tell patients is the cost, right? So in Israel, Europe, in Europe, especially in the EAU guidelines, it's up there first line with Viagra, Cialis, low intensity shockwave. It's covered by insurance. We're it's not there right now, and so it's cash pay. So for 6 sessions, it's $2,000, and it's something, if you're a good candidate, I think it could certainly help. Next is injection therapy. So injection therapy is essentially where a mixture of medication, you inject it directly into the corpora or the erection chambers of the penis, and this helps to stimulate blood flow. And it's similar in its mechanism of action to Viagra and Cialis. I mean, it's definitely different, but like what it does by increasing blood flow, but you're giving it the medicine directly into the penis, not going throughout the body. So you don't see a lot of those side effects like headache, facial flushing, nasal congestion. So the erections typically begin 5 to 10 minutes after the injection. The medicine needs to be frozen most times, or refrigerated, or it goes bad. So it can have a limited shelf life, and it's available only in specialized pharmacies like compounding urologic pharmacies. And so about 60% of men will see success with this, but as you can expect, you're putting a needle in the penis. I mean, it's very small, but it's a needle, so there can be pain, bruising, swelling. There can be development of scar tissue, curvature, and then the prolonged erection thing, or something called a priapism, can be seen with this, which is where the erection lasts longer than 4 hours, and you got to go to the ER or your urologist's office to have that taken care of. Once again, men's health clinics are getting involved in this, and so I see patients where they get an erection given to them at a men's health clinic, and then it lasts too long because they overdose them, and then those guys don't know what to do, so they end up with us to take care of it. So once again, be careful with your penises. Yeah. So implants, penile implants. So this is what I would say is, after you've exhausted all options of medical therapy of erectile dysfunction, which is everything we have talked about before this, then if you're still not able to get an erection, then penile implant works exceptionally well. So there's over 90% patient and partner satisfaction with the penile implants. And they have been around decades, going over 4 decades now. And so they've stood the test of time. Penile implants have been around longer than Viagra, Cialis, injections, things like that. And so essentially, there's the way it works is, so there's two types of penile implants. The most common type of implant in the United States that is put in is an inflatable penile implant. So this is one that has a pump in the scrotum, cylinders in the penis, and a reservoir that is tucked in the abdomen. So when you want to have sex, you'll pump the pump that's in the scrotum, and then that will pull some fluid into the two erection chambers that are in the penis from the reservoir. And then when you're done, there's that little notch on it that you press, and that releases the fluid back into the reservoir. So a few things about this. This is fully inside the patient. There's no part of this that is external. So if you're in an airport metal detector, it will not go off. Safe in an MRI machine. And if you're in a locker room, no one will know you have it. So it's very discreet. Now the implant, it's a short procedure to put it in, about an hour to hour and 15 minutes. You're asleep for that. You have, in my hands, I put a catheter and a drain that you'll have for about a day or two that will remove thereafter. And then we wait about 4 to 6 weeks. Once the stitches absorb, the swelling and bruising go down, and then we show you how to use it, and then you're off to the races. So benefits of the implant, I mean, it gives you, the main thing I tell you, it gives you peace of mind. You can perform in the bedroom. You're not always, like with any medication, whether pills, shots, shockwave, it depends on all those things I talk about: stress, sleep, smoking. It's going to work every time. So you can, and the key is you're the one who decides how long you leave it up. And if even after you orgasm, you can keep going, which a normal man cannot. So that's one benefit of the implant. The two complications we think about with a penile implant: the risk of infection, just like any artificial knee, hip, heart valve, any implant in the body, 1 to 2.5% risk. And that risk is mitigated by things such as doing the surgery fast, but safely but fast. So I personally do over about 100 of these a year. So we do one of the most in the country for this. So we have certain tips and tricks that we can do to minimize the risk of infection. And then the type of implant I use has an antibiotic coating. So a lot of things we can do. And then because there's fluid moving back and forth in the implant, it can pop a leak, just like your car tire can pop a leak. So the risk of that is 6% at 7 years. Or a new study came out in August last year, 52.6% of these were 20 years out. So it's a 50-50 chance 20 years after it's put in, if it's working or not. That's not as big of a deal. If it happens, you take the old one out, put a new one in. And then the other type of implant, real quick, so this is not done as commonly in the United States, but certainly I do a lot of these too, is a malleable implant. So instead of, there's no pump, there's no reservoir, there's just two cylinders in the two erection chambers of the penis. So when you want to have sex, you'll move it up. Otherwise, you can bend it down. Great option if someone doesn't have good hand dexterity, a Parkinson's patient, or something like that. Or a lot of times I like this in patients who are very overweight or obese. They have a buried penis. They have not seen their penis in years. So I recently did a case where we also removed his lower fat pad, and he had a really, 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 really nice result. We were very happy with that. So, that's a great option in well-selected patients, or someone who has an extensive surgical history, as well. We sometimes consider that. So we're going to show you a quick video of the implant, just an animation of how it works. So we're just going to get it lined up here. Give us 1 second. So there's two companies that make the implant. This is one of the companies' video, I think. Here we go. So all right. So as you can see here, they're going to show you. Yeah. So the cylinders are in the two erection chambers of the penis, and so the penis is like an iceberg. So what you see on the outside, you can see it's kind of going far inside as well. And then there's the pump that's in the scrotum. Discreetly, we kind of put it in between the testicles if we can. So you can see the patient is pumping the pump, and then that's pulling the fluid from this reservoir that's tucked deep in the abdomen into the cylinders. And then you have a nice, firm, rigid erection. And you are the one who lets it down. So then on the top of the implant, that little notch, you'll press that, and then you choke the penis with the other hand like he's doing, and that pulls the erection down, or pushes the fluid back into that reservoir. So once you get the hang of it, it's pretty, it's like driving a car. At first, it's kind of hard, and you have to think about it. If anyone's had to teach their kids recently how to drive a car, but then once you get the hang, you don't need to think about it. So but like I said, over 90% patient and partner satisfaction. And really what I hear from most men is, I wish I did this sooner, but it's a good option. So I think that's all I have today. I want to really spend the rest of our time today on questions and things. So please, we have a few that have already come in. So please, give me some questions and happy to answer them. I'm going to put the slides on this page here. So just so our phone numbers, the thing I want from everyone is, please go see your urologist. We would love to see you in the office and, just individually see what's going on and help you. That's it. All right. First question: if you had uncontrolled diabetes for several years, but recently dropped 80 pounds and now have your blood sugar under control, is the damage reversible? It's a great question. I think what we know from diabetes, when your hemoglobin A1C is very high, above 8, yes, no, some of that damage that you do to the endothelium or the inner lining of the blood vessels, especially, and the nerves, is in a sense irreversible. And you'll know this if diabetics, if you feel they start getting, they can't feel the tips of their fingers and toes. Yeah, you can reverse your diabetes, which is great. I'm so happy you've lost weight and done this. But a lot of times the some of these things are kind of what's happened has happened. So, I think you may notice some modest benefit to your erections, but I don't think it's going to be night and day. So it's something that, if you can aggressively treat it, you'll be just have a better quality of life and be happier. So, 1 second. Newest oldest. Why this question thing? Sorry, guys. From the top of the bottom. Okay, I'll go from here. Can you have the treatment if you've had prostate surgery? Yeah, great question. I'd say actually many men that we actually I gotta ask, what treatment is this patient asking about? So I'm assuming they're asking about treatment. Well, okay, I'll answer for all the treatments. So yeah, you can take pills if you've had prostate surgery, vacuum for sure, like I said, treatment, low intensity shockwave. So that's an interesting one. I think the randomized clinical trials show that if you've had prostate removal for prostate cancer, it probably doesn't work as well. So I would say you're not probably the best candidate for that, but I have patients who say, I want to try it, and that's fair, because there's no downside besides the cost. Injections, absolutely, and penile implant, 100%. What is the correlation of a diminished erection and ejaculation issues? Yeah, this is a very interesting topic, I think. So what we know is that as men get older, ejaculation can diminish. Certainly the ejaculate volume goes down. Reason being that the body knows, okay, I'm not trying to have kids anymore. It shuts it down. Additionally, many men have had prostate surgery, even just to open up the prostate. They may be on a medication like Flomax that causes retrograde ejaculation and decreases the volume of semen. But one thing I think about is many men have erectile dysfunction where they're having sex and they lose the erection, or they have a partial erection, they're having sex and they're unable to climax. I think that a lot of times if we can make it so you can last longer with your erection, a lot of guys can achieve ejaculation. So it's something, yes, I do think they're intertwined. So it's a great question, but it's a complex issue. But a lot of times treating the ED helps. And then with ejaculatory issues, I like to look at testosterone levels, hormone levels. If those are off, that can be treated too. So yeah. Who administers the low intensity shockwave, doctor, nurse, or a trained assistant? It's one of our medical assistant, trained assistants. If partner is not on the same page in sexual activity, can that be part of the problem? Absolutely. I mean, I think that if you have relationship issues, or you feel, let's say, shameful of what's going on, then absolutely that any psychological or psychogenic issue can cause that. So if you have anxiety going into the bedroom, that can absolutely cause it. So I think sometimes having a very frank discussion with your partner, there's nothing wrong with that. And sometimes a lot of times I refer patients to sex therapists, and we have some really good ones in town that we refer patients to. And that this is something that can help with that, just to kind of provide a safe space to talk about these issues and really to destigmatize it. I think we're getting better as a society, but we're not there where sex is stigmatized. You can't talk about it. It's, you're weird, this, that. No, I mean, I think that it's part of being human, right? And so I think that, and people ask me, am I too old to have sex? I mean, if your cardiologist says you're fine. I mean, I am no person to tell someone they cannot have sex. I've done, for instance, penile implants in guys as young as 32. That's rare, okay, but I've done people as old as 86. I mean, it's not age is just a number. I firmly believe that. Answer that one. What implants does Urology Group use? So that's dependent on our surgeon. So I use Boston Scientific implants. That's what we train with at the Cleveland Clinic. Where I think that's the best implant. I think it has the most physiologic feel. There's an implant that sometimes, if you're a candidate, we can do length and girth enhancement implant. And really, most importantly, there's an inhibizone or antibiotic coating that I really think is key in infection prevention. There's two other companies that make penile implants. To round out the discussion, there's Coloplast, and so there are members of our group who do that, and whatever in your hands you think is they think is good is good. And then there's a newer implants coming on the market now, Rigicon. So they just have a malleable implant approved in the United States. Abroad, they have an inflatable implant. I think they're saying end of this year they'll have the inflatable approved by the FDA. But so there's a third implant coming on the company on the scene. How long will low intensity shockwave work after the 6 treatment months, years? So this is always the $1 million question. I think that it's reason being that I'll tell you, I cannot give you any answer on how long will pills work, vacuum, low intensity shockwave, or injections, because these are very dependent on your weight, your sleep, diabetes, prostate cancer, everything, right? Like what are you eating? Are you not sleeping? Well, you drinking a lot of alcohol before you smoking cigarettes? The only thing I can tell you data on, like I did, is penile implant, right? Because it takes all those factors out of the equation. It's a device. It's going to work this many times. It fails X amount of times. So low intensity shockwave therapy, because everyone wants a guarantee. There's no guarantee on any of these things, right? And so I think that what the data, like I said, 2 to 4 point increase in IIEF scores. And so it helps in mild to moderate erectile dysfunction. Now, what's being studied right now is, after, is it 6 months or 1 year, do patients need a touch up, with 2 more sessions? And that's still the answer to that is not clear yet. But it's similar to, like, for instance, if anyone's partner, they get Botox to your face, right? So to reduce wrinkles. Do you do that once and never go back? No, right? You go back every 6 to 9 months and get that redone. And if you don't, then the wrinkles come back. So that's the thing, because everyone is aging, right? And so erectile dysfunction in the natural history is that, it may progress regardless. So, but that's the answer to that. Curious why you didn't mention the P shot. I believe this is where they draw blood, spin it down, and inject platelets into the penis to stimulate new blood vessel growth. Is this a scam? This is a great question. I would have. I don't want to. That's not for me to tell you if it's a scam or not. I'll just tell you what the American Urologic Association guidelines say. That's an experimental therapy. It should not be done outside of the confines of a clinical trial done at an academic medical center, for which you should not be charged money. That's what I'll tell you right now can be said. But I did read an article in last month's edition of the Urology Gold Journal that maybe there is some benefit, but they're not sure yet. So, but regardless, I think that in this market, anyone who's offering P shots, I don't think any urologist is offering. That's what I'll tell you. You should look how much money they're charging. I would not recommend that to any of my patients right now. Will this change? I'm not sure, but there's no randomized clinical trials that have been validated right now that I have seen that show that P shots work for erectile dysfunction. Can taking psilocybin interfere with erectile dysfunction? So psilocybin is an alpha blocker. Hard to know. Potentially, I haven't seen much data on that. I'm not sure. I don't think so. No, I don't think that's probably your main cause of that. So it's just like tamsulosin, like Flomax. So generally not. I have not had any major surgery to my pelvis. Why do I have ED? That will, you should come into the office to we have to do a full understanding. I think it's, pelvic surgeries, as you saw, one of the causes, right? So there's many other, maybe your testosterone levels off, maybe you're obese, diabetes, smoker, maybe you're just getting older like all of us. I'm not sure. Can you put up the slide on how erections work, image of the penis? First slide. Sure, I can. Okay, there's that. Is there a step between PD5 not working and implants? Yeah, so I think that all those things, vacuum device, low intensity shockwave, injection therapy, so all these things can be considered guideline concordant with steps before a penile implant. Yep. Will wave therapy ever become covered by insurance? I think so. I think it may in the future. It is in Europe because it's in their guidelines, and we're always, AUA is sometimes behind the EAU in guidelines. I think they wait for sometimes, so it may become in the future, but hard to say right now. Okay. I quit smoking cigarettes in January after 30 years, but I vape with a low amount of nicotine. Could the vape be causing me to still not have full erections? My EQ went down about a year ago at 47. EQ, I'm not sure. Emotional. Okay. The vape could absolutely still be causing you to not have good erections. I think you should stop vaping as well. So that's my recommendation there, just for your overall health. And so, you see all these vaping related pneumonitis, and so it's not free of problems. But you got to think about the damage that has been caused to your blood vessels, especially after 30 years of smoking cigarettes. Is just like that diabetic question. There's some things that, it helps that you're not doing it further. That's a great thing you're doing for your health, but what damage has been done can be done. So, I think that coming in and being evaluated and, us going through options can absolutely help. I've read about venal leak. Please explain. Venous leak is what this patient is talking about. So in this slide, it talks about how erection can compress the veins so the blood can't leave the penis. So there's some thought that if the veins, the blood leaks out, essentially, that you can't maintain an erection. Yeah, I think mechanistically, absolutely, venous leak is probably part of an erection, as is not getting good oxygenated blood flow to the penis. I think this all relates. What I'll tell you is that it doesn't really change the treatments, and that's what people get hung up on. Well, can you tighten the veins and things like that? No, they tried this many years ago before. They tried vascular surgery essentially for ED, and none of it has ever worked. So there's nothing really that treats that specifically, but it is probably implicated in the pathophysiology of erectile dysfunction. If you can get an erection but can't hold it once it's time to start intercourse, you're overthinking because of many failures. What is the treatment for that type of issue? Yeah, it's a great question. I think that absolutely what happens is that when you can't perform in the bedroom and you feel you've kind of let down your partner and yourself, that sows a seed of doubt in your mind. And so the next time, even though maybe you would be good, if you even that little bit of doubt can just make you not perform. So I mean, potentially, we would start with pills there and see if that can help provide a boost. Potentially, if the issue is maintaining the erection, sometimes a constrict vacuum device, but more like constriction ring, that can help with venous leak as well. We think, venous leak or maintaining an erection, but most patients will say it's very uncomfortable. Injection therapy is more potent at stimulating blood flow to the penis, and that can certainly help as well. So and then lastly is sex therapy can help with that too, because if you're overthinking because of all the failures you've had, then that can maybe sex therapy can help kind of regain your confidence in the bedroom sometimes. So yeah. What do you recommend for someone who has part of prostate removed and has ED? I'd have to look into what you mean by part of the prostate. Was it for cancer or not cancer? Are you talking about like a TURP or a enlarged prostate surgery? Are you talking about like focal prostate ablation for prostate cancer? But hard to know. I mean, there's no rule on this, right? To me, it more depends on what you've tried, how are your erections? Is it just you're a 9 out of 10, or you're at a 0 out of 10 on your erections? Are you on injections already? Or, so it could be anything from all the way pills up to a penile implant. It just depends. How do you decide the size of an implant? Yeah, so just given how many we do, we have ways to try to put in the longest penile implant we can. I want to give a guy the longest they can, but it essentially comes down to how long your skin is. So if you can stretch your penis this long, we can't put an implant this long, right? So I think over 90% of patients, if not more, are happy with penile implants. I think the guys who are unhappy, I think those are the ones that live and die by the tape measure. If you are one of those patients, I try to tell you, don't get a penile implant, or don't get anything. I don't want you to. I think you need to work on self-image, go see psychiatry, and try to understand why is it that you live and die by the tape measure. So I think that if the goal is, look, I want to have sufficient erections for penetration, I want to maintain, I want to satisfy my partner and regain intimacy, those patients are very happy. So how do we decide the size? It's an intraoperative decision, and we max it out. We put the biggest size implant we can. Okay. I answered this question. If one of the problems is side effects of medicines that must be taken, will the low intensity shockwave work? Similarly, if the condition is depression partially improved by medication but still part of the issue, how will that affect success? So look, I think that most patients are on some medications. A lot of patients have mental health things that they're dealing with and are on medications for. I think that low intensity shockwave therapy can absolutely help, as long as when we do your validated questionnaire, you have mild to moderate ED, or you have some response to Viagra and Cialis. So I don't think that these things are really have been proven to be total disqualifiers or things that will jeopardize the efficacy of it. Now certainly diabetes I think will, or prostate cancer surgery will, but I don't think these as much will, but they may. So we'd have to kind of do a full evaluation. So I would advise you to call that number or scan that QR code and come and get a free consultation to really help us understand if low intensity shockwave is for you. Do you lose feelings or sensations with a penile implant surgery? The answer is no. There's no effect on sensation, orgasm, ejaculation. It just gives you an erection when you want, so you can perform in the bedroom and you can last as long as you want. So yeah, it doesn't affect sensation. Good question. My BPH seems to be getting worse. Will that get in the way of getting an implant? No, I don't think so. If you're to the point where you need surgery for your BPH or enlarged prostate, I advise that patients get urinary surgeries done first before a penile implant's put in. So let's say you needed a urolift or something like that. So I would refer you to one of my partners who does our BPH care, and they can get that taken care of. And then once you're peeing better, we can get the implant in. But yeah. Can improving testosterone levels give you results similar to medications like Viagra? Great question. I think it can, but probably to a lesser degree, just because, I think the testosterone repletion helps, yes, with erections, but really I see more benefit on the sex drive part of it. And then, just muscle mass and fat stores, fatigue, concentration, but certainly with erections. But this was Viagra really is meant, like it helps to promote blood flow to the penis. And so a lot of times that is a more vigorous response, but I think you will see some benefit with the ED meds, with testosterone. How can I manage anxiety due to ED or performance anxiety? I think a lot of times this is where I would refer a patient to a sex therapist, was they have a lot of techniques that they can go through and delve into kind of the underlying basis. And some patients, what it is it's, when younger patients have ED, I think having a low dose of Viagra, especially on hand, that can help them perform a little bit better, so they can kind of regain their mojo, or their confidence can absolutely be key. So, a combination of all these things can help. Are there certain meds that can interfere with ED in a healthy patient? There's certain meds that can interfere with erectile dysfunction in a healthy patient. Yes. So some that come to mind: psychiatric medications can cause erectile dysfunction. such as lithium and things that are used for bipolar or things of that nature. Then prostate cancer medications that cut off testosterone levels, like Lupron, can cause that. So some blood pressure medications have been implicated in erectile dysfunction. So yeah, so we'd have to really do a deep dive into your medications and see. But I'll tell you, I very rarely tell someone, hey, stop this blood pressure. I mean, I can't tell them to think of the last time, because you got to treat your blood pressure to live. So maybe your primary care can adjust the dose, but you got to think about it. Like, if you have a high blood pressure, right? So then there's some blood, the blood vessels, there's something going on. So it's just part of kind of age that, hypertension, ED, all these things can come together. So, I mean, I think they do sometimes go a little hand in hand. I constantly catheter due to bladder dysfunction. Is that an added factor for ED? So if you doing intermittent catheterization, I think they're saying for bladder dysfunction, then that to me suggests that there's maybe a nerve problem where your bladder is not squeezing that well. So potentially, yeah, that could be implicated in erectile dysfunction. But that's not a reason you can't be treated for ED. I've done, we can start you on medications, or you can do injections into the penis for sex, or penile implant, even it can help. So, something to come see us about. Absolutely. Relative costs of the treatments. So, like I was saying, these pills, generally Viagra and Cialis, are not covered by insurance, but the generics are sufficiently cheap. Like, for instance, I know our pharmacy sells the sildenafil pills for about 60 cents a pill. So, much more affordable than Viagra many years ago when it was a brand name pill. Vacuum devices run, maybe $150. Low intensity shockwave, I told you, is $2,000 for 6 sessions. Injections, once again, insurance coverage spotty. For a vial that lasts you maybe 3 months, it could be about $100 or so. And then penile implant, actually generally covered by insurance. Surprisingly, a lot of it surprises people. So Medicare, great coverage. Commercial carriers have great coverage, and given that we're a center of excellence, high volume implanters, we get many of these covered. And so, whatever your copay is. So yeah, it's something to consider. Absolutely. With the non-pump implant, you mentioned it hinges. So does the penis remain hard but just bend when not used, or do things soften in the down position? No, great question. So we call it a semi-rigid or malleable implant. So no, it does not soften. Yeah, you bend it in whatever direction. So I'll tell you, if someone is super, super skinny, I don't think I wouldn't recommend it. But, a lot of patients who are obese and have a lot of fat on their abdomen, it can help to push the penis out. A lot of these guys have a buried penis. They're peeing on themselves. So this is a great option. And, they're not going to, people say, oh, am I going to be walking around with a hard on all the time? It doesn't seem as such, in well-selected patients, but that's a good question. Are the treatments covered by Medicare? So I kind of went through that. That the implant is insurance sometimes covers pills, shots. It's hard to know. You'd have to, they have to run the numbers. What are your thoughts on L-citrulline supplements? Yeah, L-citrulline, there is some data behind it. I think that it may help through the nitric oxide pathway. It stimulates some blood flow. I think in patients with maybe mild erectile dysfunction, you could see some benefit. It's not in the guidelines, but I think anecdotally, so the ones that we think about, those patients always want to know what supplements. So the ones that have maybe some data behind them, L-arginine, L-citrulline, ashwagandha root. So these things maybe have some questionable data. Let me see if I have anything else. I think that may. How many procedures has Dr. Babbar done? So I did 104 last year, about 70 something the year before. So, and I've been in coming on my 3rd year in Cincinnati. So we're doing top 1% of prosthetics, penile implants, sphincters in the country. So yeah, we certainly do quite a lot of these. Certainly the most in the Cincinnati market, and in actually in Ohio, Michigan, Kentucky. So yeah. What is that it? One more. And also, if I cath to urinate 6 times daily, would that interfere with a pump implant? Yeah, I mean, so, patients who do intermittent cath, they have an increased risk of infection with penile implant. Not in of itself a reason that we can't do it, okay? It's just that there is definitely an increased risk of infection. So we'd have to look into it, but I have done patients as of the such before. So, yeah. All right. I think that's all the questions we have today. Thanks so much for tuning in. It's been a lot of fun, and yeah, enjoy the weather, and please come and see us. Call us. That's my only ask. Just let's get to the bottom of whatever issues you have. So thanks, guys. Have a good one.